much. Maybe I should have done a little dance. Too late. Yeah, so the title of my talk is How Our ADHD Pathway Transformed Our Service. These are my declarations. And I want to start off like a storytelling. It's about our journey. Very recently, there was a very, very problematic fog, and that really affected a lot of flights nationwide. Developing our ADHD service is just like this picture. Very, very misty, very cloudy, very foggy, and we couldn't see the end of the road. So this is a journey that I'm going to take you on how we developed our ADHD service to what we have today. I was appointed as a consultant pediatrician in 2009, and very, very quickly was just placed in the deep end, really, I would say. And I remember my interview being, how would you develop the service? Little did I know what I had signed up for. I'll tell you a little bit about the ADHD service in Hertfordshire. So I come from East and North Hertfordshire, NHS Trust. We are, even though we are community pediatric service, we are actually linked to the acute trust, so it's not your old PCT. ADHD, and again I'll concur with my colleague who made the comment again to the first speaker, that is actually provided mainly by community pediatricians, at least in East and North Hertfordshire, with a child population of 50,000 in the north of Hertfordshire and about 60,000 in the east of Hertfordshire. So we have about 130,000 child population. And on our caseload, we have about 1,300 children. So CAMS will say roughly 300 children. And in 2009, the workforce was about 6 consultants, 2 part-time ADHD nurses, managing 1,300 patients. This is when we decided, okay, we had to develop a rationale for a care pathway for our neck of the woods. So obviously we looked at our referral statistics, we did some surveys and audits. We realized that there had been 100% caseload from 2006 to 2010 in terms of the ADHD referrals coming to us. We had an increase in workload with no increase in resources, lack of information systems, poor communication between the ADHD team and families. We identified further gaps. We realized that there was a bit of a potluck system of referrals where referrals didn't quite know, it was almost as if it was a toss of a coin. Do we refer children to CAMS or do we refer them to pediatricians? Obviously, we being supposed to be some, maybe nurturing, we realized that we were getting more of the referrals coming to us compared to CAMS. We also realized that there were duplication of services between CAMS and then community pediatrics, very poor joint working between community pediatrics and CAMS. I've always I like using metaphors, probably because of my role as a children's fictional writer. It's always this marriage where community pediatrics want to remain married to CAMS, but CAMS don't want us. That's the way we kind of think. So sorry, you do love us, thank you. I'll make sure my colleagues know that. Right, and then we also know, at that time, there was lack of psychoeducation groups for parents, children, and young people. So it was about addressing the gaps. Further gaps were in the north. In the north alone, we had 800 patients, and we had 1 part-time ADHD nurse managing those patients. Very limited impact, as you can imagine. A lot of safety issues. I mean, how do you monitor safely 800 children in only one area of Hertfordshire? Poor training, poor for schools and teachers, and also our ADHD transition was poor. So overall, the journey from referral to diagnosis, very long. I remember, I think children could wait as long as 18 months for a diagnosis, not good enough. We identify the gaps by our usual standards, and our surveys have mentioned that already. And by the way, ADHD referrals alone made up about 21% of the normal general CDC referrals coming to the Child Development Center. We did an audit in 2011, and we realized that we were getting the majority of the secondary school age children with ADHD with very complex psychopathology. So CAMS weren't getting them, we were getting them. And when they obviously came to us, then we re-referred them to CAMS. So again, lengthening the journeys. We did a survey with the autism families, families with ADHD and autism, and it was very clear that there was also still a potluck system existing even with autism. So even if you looked at the whole neurodevelopmental pathway, there wasn't really any clear system of referral at all to whether CAMS or community pediatricians. So if you look at this graph, in 2010 when we did the audit, you can see, as I've mentioned already, 20% of ADHD formed the overall sort of referrals, out of the overall referrals coming to the Child Development Center. And not surprisingly, 30% were not accepted because they did not fulfill referral criteria. So if you have a referral referring a child, and then you, for some very little reason, we tell the referrer that no, this child doesn't fulfill criteria, you are lengthening the journey. Not good for children. We identified a clear aim and objective. We wanted to be clear about where referrals had to go to. Do they come to community pediatricians, or they go to child and adolescent mental health services? Starts eliminating the potluck system of referral. We wanted to provide clear lines of communication between service users and us. Uniform service, so we didn't want CAMS to have the service, East and North to have the service. We wanted it uniform, no postcode lottery. We were clear about increasing joint working between us and the adolescent mental health services. We wanted also our pathway not only to signpost, but to inform and educate. And at the same time, it being very usable by informing commissioners, just in case we needed more resources to support children and young people. And obviously expanding the role of the ADHD specialist nurse service. So quite a lot of things in terms of objectives for our pathway. So we've set about developing this pathway. I led it, I facilitated it, and if you can imagine a new consultant, and it was good because 7, 8 years on, I think if I knew what I know now, I probably wouldn't have started it. But sometimes when you're very naive, in your innocence, you just go in. You are not aware of the foxes out there, you just get on with it. So I invited professionals from all over, all the relevant stakeholders, psychiatrists, school health, ADHD nurses, managers, commissioners, everyone that felt was relevant to develop the pathway. We held monthly meetings. We had very good non-promotional support from the Shire. Commissioners, I remember at that time it was the PCT and not the CCG, were keen for our pathway to also reflect the generic county-wide pathway. Because in East and North Hertfordshire, we also have the West Hertfordshire, which were, even though we had the same commissioners at that time, were a completely different service then from us. So if you can imagine, it took us 18 months, to develop a pathway, but that's how long it took us. It's very frustrating. And like I said, if I knew it was going to take me 18 months, I probably wouldn't have started it at all. So the official launch came in. You can imagine somehow, long hair is now short. I think that comes with age. Right. So what it consists of, we have a guidance notes, it's nice, compliant, it did all we set it out to do. We didn't only just have booklets, but we have electronic copies of our pathway. It's user-friendly flowchart as well, checklists, sample letters, the whole lot was there. just to make sure carers, referrers are clear about what to do when they are referring children to us. And obviously, we will be updating it following the update of the 2008 NICE guidance. The progress. This is what's the important thing is the progress. Okay, and so I'll show you. So following a few years on, what has happened following our pathway development. Okay, I want to look at this. I want you to look at our referrals. So if you look at 2009, so this is the general CDC referrals and the proportion of ADHD, okay? So in 2009, 19%, 20% was made up of ADHD. So if you can look at 2010 to 2014, there hasn't been much change, just a very little reduction in referrals, but there is a reduction, which is quite good news. Declined. I don't like ADHD referrals being refused because it means that, it doesn't necessarily mean that it's a wrong referral. It means they haven't done something, they haven't given enough information. And in doing so, you just lengthen the child's journey. So if you can imagine, following the pathway, we've reduced those refusals from 23% to 14%. And we're still bringing it lower and lower and lower. I am one of the ones who do our referral allocation meetings, and now we hardly decline referrals because most of the time, by the time we get the referrals, we get the full information. So it's taking 6 long years. 6 long years, no less than, but a few more years. Okay? Children, the secondary school age, like I said, they do tend to present with complex psychopathology. And with Child Development Center where you don't have psychology input. And we did struggle with it. So following the audit and the pathway, if you can see, in pre-pathway we had 53% of our ADHD referrals made up of secondary school age children, and now it's down to 28%, and again, going down. That means what happens is there's a single point of access where the referrals go to, and a lot more of the secondary school age complex goes straight to CAMS. The ADHD nurse input before pre-ICP, hardly any input before the diagnostic assessment. It started going up, so now we've gone from 0% to 16% and increasing. Feedback before ADHD appointment, pre-pathway. Yes, we would receive some feedback before the consultation, so looking at schools, clubs, any, corners, Vanderbilts, SDQs. 68% will get some pre-feedback. Now, if we look at post-pathway, it's 94%. So in 94% and increasing, before we see the child, we've had all sorts of feedback from everywhere, including sometimes ADHD nurse school observation. This is the bit. Average number of consultations before ADHD diagnosis. We don't have the QB test yet. Hopefully we will in the future. But let's have a look at it. Pre-ICP, you will get an average, 53.3% of children will have an average of 2 consultations